everyone. I hope and I believe you all are doing great. This is Dr. Arya, your pathology faculty, and today we will be studying about the ischemic heart disease. And let me tell you one thing very clearly. One long question is expected from this topic. So it is that important in your pathology. Okay. One long question is very much expected from this topic. Now, before starting, let me just highlight this part, that ischemic heart disease is when the heart doesn't get enough love. Okay. By love, I mean the heart does not get the proper blood supply. Okay. So the heart doesn't get the enough love because the world is very cruel, right? Anyway, this was just for the fun part. What is ischemic heart disease? They are basically a group of clinical syndromes. We will be studying the syndrome separately. Like you have the angina pectoris in that, right? So it is basically a group of clinical syndromes which results from the myocardial ischemia. Ischemia means the loss of blood supply, and we have seen here that in this condition there is a loss of blood supply to the heart. Heart does not get enough love. Okay. So it is due to the imbalance between the coronary blood supply and the myocardial demands. It is basically a demand supply mismatch which happens, right? Let me just give you an example. Let's say that you want something, right? And you went to the market to get that. But you didn't got the same product. You got a product which is similar to that, but you didn't got the same product. So there is some mismatch which will happen in your brain, then also you will be adjusting to the environment. You will be adjusting and satisfying with that particular thing which you have got, right? Similarly, in our life also, sometimes we don't get what we want, but we sometimes adjust, right? So there is a basically imbalance between the coronary blood supply and the myocardial demands. What are the risk factors that are included? Risk factors, if there is a question on the CVS, the risk factors should be classified into the two categories, non-modifiable one and the modifiable one. Okay. Now, in the non-modifiable one, I have already told you the risk factors which you can, cannot be modified, like your age, your gender, your family history, and your genetics. They cannot be modified. What can be modified? Hypertension. Right? You can lower the BP of the person, or you can in normotension, basically. Okay. Then diabetes. China has introduced a technology by which we can reverse type 1 and type 2 diabetes, right? Smoking cessation. If the person stops smoking, he will not develop the 𝗵𝗺's disease, right? Obesity, if the person was undergoing a surgery, then he or she is required to maintain the weight and to lose certain amount of weight, right? Most importantly, sedentary lifestyle. Okay, you have to change your sedentary lifestyle and make yourself active and make your lifestyle a active lifestyle. Okay, so these are basically the risk factors that you have. You have the non-modifiable one and the modifiable one. Okay. Let's just understand the pathogenesis in general, okay? Because we will be discussing about the pathogenesis of each and every disease separately also. So this is the basic general idea which I am giving to you all. First one is the atherosclerosis. Atherosclerosis is one of the most underlying cause, and we have seen this in our previous video also, that atherosclerosis alone contributes to the 50% of the deaths, right? What happens? There was plaque. In a four-way highway, what was happening? All the cars were diverging towards the one way. As a result of which, what was happening? There was a narrow pathway and the blood flow will not happen in a proper manner. What are the components you have? You have the plaque formation, you have the fibrous cap, lipid core, and the inflammatory cells, right? Let me just draw the figure for you again so that it will be easier. You have this blood vessels. Then you were consuming a lot of chips and carbonated drinks. Now what will happen? The blood flow will decrease the blood flow. Blood flow decreases. Okay. Next you have is the determinants of ischemia. What are the determinants of ischemia you have? First one is the oxygen demand, that is for the heart rate, contractility and the wall stress. Second, you have this the oxygen supply. If there is a less oxygen supply, this will affect the coronary blood flow. That will affect the coronary blood flow. And we have read about ischemia in our journal Pathology. If you are not thorough with ischemia, please go and watch that video of ischemia, okay? Because that will be very good for you to understand the further things. Next you have is the plaque changes, which leads to the ACS. What happens is there is a plaque rupture. There is a plaque rupture, as a result of which there is a exposure to thrombogenesis. And what happens then? After the rupture, the plaques get aggregated towards one place. Then they form the thrombus. After the thrombus, there is erosion and hemorrhage, and then occurs the acute coronary occlusion, Okay, so this was a brief about the pathogenesis, right? Next, see guys, listen to me very carefully, read this chapter very thoroughly, because it is expected that one long question answer will be from this only. Okay, so it is that important. Next you have is the angina pectoris. Either the short note will come or if the LAQ will come, then you will write this in the LAQ, okay, about the angina pectoris. Let's start about the angina pectoris. So angina pectoris is paroxysmal substernal chest pain due to transient reversible myocardial ischemia. You know, what is the classical presentation that the patient will come? I'll show you the figure. See, look at this old man. You know what is this sign called as? This sign is called as the clench fist sign. It's like this. The patient will come like this, okay, and they will have a lot of chest pain, right? Okay. So what is the pathophysiology behind this? There is basically an imbalance between the myocardial oxygen demand. There is an imbalance between the myocardial oxygen demand. Now what happens is there is a supply side factors, that are the oxygen content will be reduced and there will be coronary artery stenosis that will happen. I will show you the figure. I will also tell you about the stable angina and the unstable angina. Just wait for a moment, okay? Then what you have is the demand side factors. What happens is there is an increased heart rate, then there is contractility and wall stress. Obviously, if there is a plaque which is getting accumulated, wait, I will draw a figure for you all. If there is a plaque which is getting accumulated, obviously when the blood will come, the walls will try to push. Right? As a result of which, what will happen? When the blood flow is very fast, the heart rate will also become very fast, because you have read this law in your physiology chapters, and if you don't know that law, you have to watch the physiology lectures as well then. Now, see, I have drawn there is a flow chart, and if the question will come now, please draw this flow chart. It will fetch you a lot of marks in your exams, okay? What happens is, first there is a damage to the endothelial layer. Obviously, whenever there is any mechanism that will happen, first thing that will happen is the damage to the endothelial layer. Now what will happen? There is a deposition of cholesterol and lipids in the intimal layer, and I have told you about the layers that you have. What are the layers that you have of artery? Tunica externa, media and the intima. Externa was the outermost layer, intima is the innermost layer, and media is the middle layer, okay? Now what happens is there is a cholesterol deposition. Oh my god, there is a cholesterol deposition in the intima layer. There is a cholesterol deposition in the intima layer. Okay, now what happens is, after the cholesterol gets accumulated, the lumen diameter, see, this is the diameter. Won't you think that the diameter is reduced? The diameter, I'll draw it properly, just wait. I think the figure is not clear, so I have to draw it clearly for you guys, right? You also draw it with me, okay, so that it will be beneficial for you at the end. You will remember all the things. You have this blood vessels, this lumen you have. What happened next? The cholesterol or the lipid was accumulated. See, this is the cholesterol and this is the lipid. Now what happens? Earlier the diameter was this much. Now the diameter has reduced to this much. Now the diameter has reduced to this much. So the diameter also reduced. Now what will happen if the diameter is reduced? There is a decrease in the myocardial blood supply. Obviously, how the blood will flow, right? If there is no passage for the blood to flow, how the blood will flow? If there is no four-way highway, how will the vehicles go? In one way, right? Next you will be having is the imbalance between the myocardial and the oxygen supply. There will be a imbalance. After the imbalance, now the patient will develop angina pectoris or the stable angina. What is stable angina and what is unstable angina? If there will be a question on angina, now they will ask this. What is the difference between stable angina and the unstable angina? So we are very smart. We will study that also, okay? You have two types of angina, unstable angina, stable angina. Look at the figure very, very carefully. What you are having in the unstable angina? In the unstable angina, you have the plaque which is there, right? Then what happens is there is a thrombus. What is a thrombus? Thrombus is basically a blood clot or a plaque. Then you have the coronary arteries. These are the coronary arteries. What happens is there is a pain. In unstable angina, there will be a pain during exercise or rest, but it goes away. See, unstable angina is far, far better than the stable angina. You know what? Because here the plaque will not rupture. Okay. Here you have certain amount of space for the blood to flow. But here in the stable angina, you don't have that much of space for the blood to flow. And if a person is having unstable angina, the pain will be when he or she does any vigorous exercise like dancing, like cycling, running, right? In the unstable angina, stable angina, it is the most common one. Okay, the coronary artery, there is a reduced blood flow and it will get less oxygen, as a result of which what will happen now? There will be a ischemia. There will be a ischemia, and ischemia is very, very bad. Why? Because there will be no blood supply. If there is no blood supply, how the organ will meet the oxygen demand, right? There will be a demand supply mismatch. So this was all about the figure. Okay, this was all about the figure. If the question will come, you have to draw this figure because they are very, very cute. Okay, next you have is the types of angina. What are the types of angina you have? First one is the stable that we have seen. So stable one, the cause is what? There is a fixed artery, atherosclerosis. They do not move. The plaque do not move. What are the predisposing factor? Maybe the person is having a lot of exertion, right? Maybe he was doing a 36 hours of duty in his hospital. Emotional stress, very, very common, right? And see how I changed my tone when I talk about emotional stress. Anyway, next is cold exposure. Obviously, if there is a people who are living in lower temperatures, the people are living in lower temperature, and if they are not used to that temperature, then what will happen? Their body is unable to adapt that environment for a certain amount of time, right? Next, how will it be getting relief? First one is rest. If the patient is on rest, then they are relief. Okay. Nitroglycerine, they can give. That you will read in your pharmacology. in nitroglycerin, what happens is there is decreased demand of vasodilation. There is decreased demand of vasodilation. Now, what are the pain characteristics you have in this? First one is the substernal pain will be there, okay. Then there will be squeezing or heaviness that your chest will feel. Then it will radiate to the left arm and the jaw. The patient will be having pain in the left arm also and the jaw also. The patient will come to your clinic and tell you that, doctor, my pain is radiating towards my arm and my jaw, okay. So you have to make a differential diagnosis of stable angina. Then it lasts for less than 15 minutes, okay. What is the first thing that you will do when a person of chest pain will come to you? Don't tell me that you will give Pentop, okay. First thing that you will do is ECG. Because even if it is a case of acidity, you have to do ECG, right? Because many of the students have said that they will give the patient Pentop. Okay, you have to give him or her Pentop, but first do the ECG also, right? So in the ECG, what you will be seeing is ST depression. See, I know you are not thorough with your medicine or you have not started reading your medicine, but I think this much you know in your physiology that there is some PQRST are the waves. So in the ECG, you will be having the ST depression plus or minus the T wave inversion during the pain. Okay. Pathology, you will be having the transient ischemia, but there is no necrosis. There is no necrosis that will be there. Okay. Next, this was about the stable angina. What are the points we have got from stable angina? First one, it's fixed. Predisposing factors, exertion, emotional stress, cold exposure, relief, rest or nitroglycerin. So, if there will be a case-based scenario that will be given to you, they will mention that the pain get relieved on taking rest. So, please, I am highlighting also. Please just take this thing into consideration, okay? Next, what are the pain characteristics? Substernal squeezing radiates to the left arm. Second hint, radiates to the left arm. ECG, ST depression, T wave inversion during the pain. Right. Next, chalo. Next we will be having is about the unstable angina. Unstable angina is like the unstable people, right? They don't know what they want to do in their future. Spineless people that we call them, right? So you have the unstable angina. What are the causes of unstable angina? You have the ruptured or the eroded plaque. See, in this, the plaque will be ruptured. Okay. Like, I'll draw a figure. You have to draw a lot of blood vessels in your CVS chapter, right? Like when we will be doing the CNS now, we will not drawing the brain every time. But here, blood vessels are easy to draw. So we will just draw it. So here what happens is, okay, let me just draw another one. It's not a concrete pipe, okay. This is your blood vessels. Assume it's your blood vessel. So what happens is, the plaque here, your plaque will get ruptured. The plaque will get ruptured. What are the features you have? Features you have is the pain at rest or with minimum exercises. What was happening in the stable angina? The patient was getting relief from pain, right, on rest. Then you have the new onset angina or the increasing frequency it has. Duration is more than 20 minutes. And in the stable one, you were having the duration of less than 15 minutes, right? Next, in the ECG, you are able to see the ST depression, T wave inversion and the troponin. See, troponin are the cardiac markers that you do, okay? And they are of more significance in your myocardial infarction portion because they signifies in your forensic also. This basically signifies that the time interval of the death, okay, these markers. What is the clinical portion that you have? They are basically a part of acute coronary syndrome. Third you have is the Prinzmetal angina. What are the cause? Cause are the coronary vasospasm. The coronary arteries goes into the state of vasospasm. What are features you have? They occur at rest. Okay. They are often nocturnal. Nocturnal means they occur during the night more. Then they are not related to the exertion above that we have studied. Stable angina, unstable angina, they were related to the exertion. This is not related to the exertion. It's not related to the exertion. Okay. So how does it get relief? You get relief from it by taking the nitrates, by taking the calcium channel blockers. In your pharmacology now, you will be having a question on calcium channel blockers. So please read about the calcium channel blockers. See, if you are studying the second year subjects now, pathology, microbiology, pharmacology, they are so integrated subjects, and please study them in an integrated format. Like if you are studying pathology CVS, then try to study it from pharmacology also, the pharmacology CVS drugs that you have, so that you will be having a very holistic approach towards everything, right? And that's what's required in the medical field. Next, fourth you have is the microvascular angina. What are the causes? Causes are the normal epicardial arteries. They are most common in the women. They present like stable angina, but angiography is normal. This is basically the differentiating point you have in the stable angina and the microvascular angina, that when you do the angiography of that person, the angiography comes normal. Okay. Let's see the clinical features of angina. Chest pain, there will be pressure, heaviness and tightness. Okay, there will be so much of pressure that the person will be feeling. It radiates towards the left arm, jaw and neck. Okay, associated with dyspnea, sweating, palpitations. You know what is palpitations? Like when you are sitting in a very quiet room, or maybe you have watched a horror movie, right? The horror movie which is coming right now is Conjuring the Last Rites, I guess. Okay, so you watch that movie, and when you are alone in that room, you are able to feel even the clock, right? That tick, 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 you are able to feel. Similarly, this person, okay, I'm not recreating any horror movie scene, but this person starts developing palpitations, means they are able to feel their own heartbeat, right? Without even touching, thok, 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 thok. Okay, like this. Then you have is the Levin sign that I told you. The clench face sign that the person will come. Okay. What are the investigations you will do? The investigations you will do, first thing, not the pen top that you will give. First thing that you will do is the ECG. In the stable angina, you will be seeing there will be ST depression during the exertion. When the person is doing a rigorous amount of exercise, then there will be ST depression. Prinzmetal angina, you will be having ST elevation during the attack. When the patient is suffering from that particular disease, then only the person will have the ST elevation. In the unstable angina, you will have the ST depression. In the unstable angina, you will have the ST depression, right? Then you have something called as a stress test. What is a stress test? It is a treadmill test. Okay. What happens now? There's a treadmill test, and you have it is also called as a dobutamine stress test that you will learn in your medicine lectures in your final years. But what happens is, when you go to a cardiologist, what happens is they suggest you a treadmill test, and then there you have a treadmill. For that you have to walk for around 5 to 10 minutes. They will connect all the leads to your heart, and there you will be having the heartbeat. Basically, they will show that what is the increase in the heart rate that you are having during the exercise and during the walking process. Okay. Next you have is that you will do is the stress echo. Either you can do the 2D echo or either you can do the 3D echo. although 3D echoes are very expensive. Prefer doing the 2D echoes only. Then you have the nuclear perfusion scan that you will read in your radiology. That's not important. Coronary angiography is a gold standard. Okay, coronary angiography. If the person is a layman also, he will tell you if you are having this chest pain, he will ask you that is your angiography done? Although he or she don't know anything about angiography, but still they will ask you, is your angiography done, right? So it is basically a gold standard, that gold standard that every person knows about angiography. Then obviously you will do the blood test. In the blood test you will find the troponin levels are normal in the stable angina. Okay, what is the management you will do? First, you have to take the journal measures. Obviously, I have told you, before even starting the patient on medication, it is very, very important to see that are the conditions reversible when if the person starts living a healthy lifestyle, right? It's very, very essential. So first thing is, first line of treatment is obviously the lifestyle modification. Stop smoking. If the person is a chronic smoker and continuously smoking, consuming around 1 packet daily, although I don't think so anyone out there consumes 1 packet daily, but there are few people who consumes 1 packet of cigarette daily. It's not good. You should not do it. Weight loss. Start eating healthy. Start living a healthy life, right? Stop consuming these chips and carbonated drinks. They are good for just once in a while. Once in a blue moon, it's good. Exercise. It's very, very important to live an active life, because if you are living an active life, then you are not even under the radar of any disease, right? Drugs. Obviously, after taking the journal measures, the person is not able to recover. Then we will shift the person to the drugs. What is the first line of treatment? You will give the nitrates. Okay, you will give the nitrates, and then what happens is they are basically the venodilations. They decreases the preload and decreases the oxygen. Then you will give the beta blockers. What they do? They decreases the heart rate and they decreases the contractility. See, although it's not my department to teach you pharmacology, but I just want my students to have a holistic approach towards any subjects, because if you are studying in a holistic approach, see, the patient will not come to you like, I am a pathology patient, just treat me according to pathology, whatever you have read in your pathology. Or the person will come, see, I am a medicine patient, just treat me in a way that was taught to you in your medicine lectures. So I want my students to have a very, very holistic approach towards each and everything, and not only in subjects. Have the holistic approach in your life as well. Okay. Now, next thing that you have is they are the calcium channel blockers. So you have the dihydropyridines. They are basically the vasodilation. I'm just giving you the mechanism by which they work, what they basically do, is the drugs and all that thing that you have to see in your pharmacology lectures. Then you have the antiplatelets. They are the aspirants and the P2Y2 angina. Okay. What is the intervention that you will do? You have the angioplasty. This also the common man knows, right? So you have the angioplasty and stenting. He will ask if there was any stent that was placed, right? These are very common. Then you have the CABG, that are the bypass, coronary artery bypass grafting. That is basically the proximal left artery involvement. Okay. What are the complications that you will have? The complications will be, if the person is not recovered well, then the disease may progress to the myocardial infarction. The disease may progress to the myocardial infarction. There can be ventricular arrhythmias. What is arrhythmia? Arrhythmia means there is the rhythm of that person. You have, what are the things that you have? You have read in your physiology, rate and rhythm of the heart, right? Either the rhythm is regular or either the rhythm is irregular. So in the arrhythmias now, the rhythms are basically irregular. Then you have the sudden cardiac death. There is a sudden cardiac death that the person will have. Okay, so this was all about the angina that we have read. Now we have seen that angina will progress to the myocardial infarction. So our next topic will be about the myocardial infarction. Before that, let me just give you a question, because how can we forget about the question, right? So I'm giving you a question. There's a person comes to the clinic with chest pain. Okay, and the chest pain is relieved on lying. Relieved on lying straight. What is the diagnosis that you can make? The diagnosis that you can make from this given history also is about the stable angina. Is about the stable angina. Okay. So this was all about the angina portion that you have. This was all about the angina portion. Please see this figure very, very carefully. See this pathology portion and the definition, and you are good to go about the angina pectoris. Thank you so much. I hope you enjoy this lecture. If you are having any kind of doubt, you are free to ask me. You are free to DM me. Okay, thank you.